First and foremost, what is occupational therapy? So occupational therapy in the context of CMT, we focus on hand and arm concerns, but we also focus on a lot of other things too. So we help people with self-care skills, the things that we call instrumental activities of daily living, which includes household management, laundry, chores, all of our most favorite of things. We also focus on leisure activities and play, and educational and employment pursuits. So basically anything that you feel like you're having a hard time with, we're happy to help you problem solve and create solutions so that you can be more independent. All right, so we're gonna go through pediatrics. I'm gonna share with you guys some of my favorite stretches for kids, and some of these apply to grown-ups also. So the first one is a pec stretch. This is one that we have a lot of trouble with because we live in a society where we're on our phones all the time. I literally just asked you to get your phones out. So we're on our phones all of the time, and that creates a really hunched posture. And we were to work on having an improved posture. So this is one where you just lay on your back, arms out to the side. You can modify it in a lot of different ways by putting your arms up or down a little bit. But the goal is to have a low load stretch through your pec muscles, and it should feel really, really good and help you with your posture. The second two on the screen, so the middle one and the bottom one, are another favorite. So this one, we want to put our hands together like so, keeping things lined up as best as you can. I see some of you practicing, love it. So putting hands together and then bringing them down. You should feel a little bit of a stretch through your wrist and your forearm, and that's really lovely for helping to keep those finger flexors nice and loose. All right, my last favorite stretch. So a lot of my kids will complain of cramping with handwriting. So, and many of you guys might be experiencing that also. So this one, we want to push through the thenar eminence of our hand all the way down the muscle, and it should give a really nice release. Feels kind of lovely. I'll just sit here. Okay. All right. The next set is all about exercises for kids. So we work a lot on core strength and shoulder strength with our kiddos. The foundation of our body is our core, and we want to make sure that our core is nice and strong because it helps facilitate the things that we do out in our hands. So these are just some different examples. I do a lot of yoga with my kids. So the first one is working on downward dog to plank. This one is lovely for working on shoulder strength and core strength. The next one is a really great example of a forearm plank. Forearm planks are great because it helps take the pressure out of your wrists. So anytime that we're doing weight bearing through our hands, we want to make sure that we're doing it at least on a cushy surface or using our forearms instead. The third picture is what we call cobra pose. Cobra pose helps us get our back muscles nice and strong, and it helps open up the front line of your body. And last but not least is a spinal balance. This one helps with a co-contraction of your flexors and your extensors with those deep spinal muscles and keeping them nice and strong. All right, not only do we work the core, but we also work on hands. So the thought behind this is that if we can keep our hand muscles nice and strong, that they will stay that way longer. So on the right side, you will see some putty. We also use Play-Doh in pediatrics or modeling clay, but this one helps keep our intrinsic muscles, or the little muscles inside of your hand, really strong. The second one is working on in-hand manipulation skills. So I'm going to show you some pictures of some of the games that we do. We play games. That's what we do. The kids think it's fun, but actually they're working really hard. So Mancala is a really lovely example. The kids pick up the marbles one at a time and then put them back in one at a time. The next one is this cute little caterpillar game. It has some tongs, which put kids into a really great position, and that way they can work on precision and strengthening at the same time. And blast from the past, we have a geoboard working on the power pinch and pull. You guys might, if you're my age, that might be familiar. All right, and we encourage our kids to stay as active as possible. So we definitely want kids to explore different options, to try different sports as they can, as long as they are being safe, and we try to modify to make it so they're successful. Okay, top tools. So you will also notice a new QR code. This is a different QR code than the first one. You'll see this new QR code pop up on upcoming slides. We have created for you guys a resource guide of our favorite tools that you are welcome to go to. It's a PDF. So this will be on future slides. So I'm going to keep going, but it's going to be on multiple. Okay, so the first one on here is Zoo Bits. If you have trouble tying shoes, these are magnetic locks that just clip together and you're off. A lot of my kids will tell me they have a hard time with dropping things. So this is why we try the pump top bottles for shampoo and conditioner, or smaller travel size bottles that are silicone, because they are easier to hold, easier to squeeze, and less likely to hurt your feet if you drop them. The next one is zipper pull. So zipper pull helps with our pinch and pull of our zipper. You can just hook a finger in it, put it on backpacks, coats, etc. And my ultimate favorite is Dicem. Dicem is this stuff in the bottom corner. It's blue. You can cut it into whatever size you want, and it's really helpful for opening jars. It's like super, super, super grippy. It's lovely. Last but not least, compression sleeves can help minimize tremor symptoms. The next two are, again, for dropping objects. Lots of my kids will tell me they drop their phones. So this is a pop socket with a ring on it, so you can put a finger into it, and then a cup that is non-spill, and also you can slip your hand into to prevent dropping. And that is all I have. Thank you.
I brought props. I'm the shortest one in the group, so hopefully I have this at the right angle. For you, Robert, straight up. So I'm Karen Hookstead. I'm the occupational therapist for adults at university. Oh, I guess I can't walk. That's going to be hard for me. So all I want to do is review, and also what the physical therapist will follow up with is
Karen,
the important.
You can walk. I'm bringing you this mic.
Thank you. I have a hard time staying in one place. So as an occupational therapist, we would be evaluating your upper body functioning. So we would look at your range of motion and measure your movement. We'd measure your strength. We would look at grip, pinch, and coordination. And then we'd also measure sensation. So part of your home program, or what we would demonstrate to an individual, sometimes we would use, obviously, some light resistive band, which we've all been familiar with. But we want to start proximally, and so I want to be really mindful that we're thinking about the shoulder and the scapular region, and then we work distally down to the fingers. So the exercise program, again, if we were working on shoulder and scapular range, we would be demonstrating to you your form, how many repetitions to do, but we're working on shoulder, scapular strengthening, so our shoulder blade, and then we proceed down to biceps and triceps. So biceps and triceps. And then part of sometimes the exercise program that is overlooked is, as we look a little bit further down to our forearm, is forearm rotation. So palm up, so supination and pronation. Wrist, our ability to extend our wrist and wrist flexion. And then the smaller muscle groups that of the hand, these are really the intrinsics which originate and insert within the hand. So they really are intended for dexterity, our pinch and dexterity and coordination. So some basic movements that we look at is our interossei, our ability, can we spread our fingers fully apart? Can we pull them in? Lumbricals, which are a little bit stronger, it's the movement we use when we're holding a notebook. So we should be able to bend at the large knuckle while keeping the middle and distal joint straight, and our thumb comes up and underneath. And recognizing the importance of the thumb and where that weakness, how that weakness presents itself. So we're looking at our ability to extend the thumb, apply a lateral pinch, bring it down to the fingers, and most importantly, our opposition. Bringing our thumb around to be able to more easily grasp objects. Wait, I went too far. So I'm just going to go through a handful. Again, a lot of these resources are available. But for adults, one of the items that a lot of people like is the upper left, the ergonomic pen. We also then can obviously build up utensils. If silverware is flat and it's migrating around in your hand, how can we allow you to be able to manipulate that object more easily? I mentioned in ergonomics, this is an image of the tabletop mobile arm support. So I always have people, I like videos of how one is functioning at work. And so we can begin to see how one might begin to compensate. So how do we get the shoulders down, our elbows at 90 degrees? How are we not navigating over the keyboard, the mouse? And there's lots of different ergonomic mice out there. Or trialing dictation. Again, lots of different tools. There's this silicone band that can be placed on most common objects to be able to give that object a handle. Hands-free hair dryers, again, the Dyson. How do we look at our handles at home? Turning them into lever arms are better than the cylindrical ones. There's ergonomic knives, ergonomic scissors, button hooks. And again, we have a whole list of different companies and different versions of adaptive equipment, or I'm sorry, adaptive clothing, down to shoes. And then a couple of other interventions if you actually worked with a therapist. The other part I wanted to show you is what I have kind of on my thumb today is just using kinesio tape or a dynamic tape. So it's a great positioning device. So if our thumbs are out to the side and we're really struggling, being able to bring the thumb around into opposition for grasp, we can use this type of dynamic tape, and we can help with just positioning the digits, most importantly the thumb. So there's, again, elastic quality. We place it and help position the thumb in opposition. There is also, we can use some low temperature thermoplasts. So this is called a short opponent splint. Again, same thing. It is harder, a little bit more rigid, but can position the thumb into opposition for function. A couple other just quick things. As we work through the day and our extensor group begins to fatigue, we'll notice that the wrist drops. So how can we provide a little bit of support? There's neoprene wraps. This is a D-ring splint to be able to give a little bit of support at the wrist for hand functioning, because as our wrist drops, we lose that power grasp and function. The short opponent's thumb, and then the last one is the resting hand splint. So if we have some intrinsic weakness or we're getting into some clawing positions, this supports the wrist, thumb, and fingers. This could be worn in the evenings or possibly at night, and all it is giving us a little bit of stretch if we're getting into some of this clawing or intrinsic weakness position. How'd I do?
Good work. So just as a reminder, I'm not going to use this. Physical therapy, pediatrics. I'll let you read what physical therapists do if you don't know, but I would like to reorient my talk a bit to some of the benefits of some of these earlier exercises, which would be of benefit for earlier diagnosis, so that we could potentially modify or keep strength as long as possible. And that, I think, has benefit for the people that we're asking, for not only the children in the group and parents, but also for grandparents. So I do kids. So I'm going to talk about strengthening, and it used to be knowledge that you wouldn't want to strengthen muscles and nerves that were already weak because it would overtax the nerve and that wouldn't be good. And now the thinking on that has changed. So if you leave with nothing from my talk, I believe strongly that movement is medicine, and everyone that I see, those of the children that I see who stay active, doing whatever activity, all very much do much better than the kids that don't
that are not active. So doing something, I think, is important. I also think doing some distal strengthening, meaning strengthening the muscles of the feet and ankles, have a lot of value. So the lower picture is a picture of a foot. Dorsiflexion is the motion that brings your foot up. If you don't have good dorsiflexors, you have what we call a drop foot, and that can get caught when you're walking and cause tripping. So early on in your CMT process, or perhaps you have a flexible foot, or perhaps you've just had a surgery to give you some flexibility, working on the dorsiflexor muscles is important. Some CMT conditions have what we call a flaccid foot, where the foot does not go up and down. That would be perhaps the one exception to this rule, but I do think trying to work on these muscles is important. So you see the green muscle is the big primary mover. In CMT, that muscle goes out early, meaning it becomes weak earlier than others, and the body is smart, it adapts, and so it calls on this smaller muscle, the toe extensor, to pull the foot up. What happens is you can see in the middle picture, the toe, that muscle is attached to the toes. So what happens when you try to dorsiflex your ankle, you get what's happening in this lower, you get that clawing of your toes. And I think that's important to understand, because as the foot changes, it's like, why is this happening? And that's why, because your body is changing to get your foot up, but it's using a toe extensor. Left unopposed, if that gets stuck, that creates problems. So you have active motion with no resistance and active motion with resistance, like the band that Karen talked about. Same thing with the muscles that bring the foot in and out. So we have inversion and eversion. The muscles on the outside of the lower leg go out first. Then you end up with a standing posture where you're more on the outside of your foot. That becomes problematic. So you want to spend some time strengthening the muscles of the lower leg that pull the foot out. If you're trying that, or in your efforts to try that, we have tools to augment strength. That's bracing, and that's a lace-up ankle brace. And then moving on to a stretching, it's also important to stretch. And I think it's pretty common that everyone knows about stretching their heel cords. There's two muscles down there, one that's stretched when the knee is straight, one that's stretched when the knee is bent. But I don't sense that a lot of people spend the kids that I see, we're trying to reinforce very early on, you have to stretch the toes into a straight position. If you don't, you can run into problems with your toes running into the top of your shoes, which if you're older, maybe some of you have experienced this. But you also have to stretch the plantar fascia, which is the band of connective tissue that runs from your forefoot to your heel. And this, if not stretched, can later contribute to the foot changes that we see. Here are tools for stretching: the wedge, the toe separator, myofascial balls. And in pediatrics, we get asked often, serial casting is a modality that a lot of therapists use for stretching. Yes, it does work in CMT to increase your range. No, it does not last. So night splints are another tool that we use. It has been shown in research that night splints do not increase range of motion in children with CMT. However, we do often use it in connection with the serial casting in order to maintain the results of the serial casting for a longer period of time. Beyond bracing, and I'm going to skip through these slides quickly. If people have questions, we can answer. But the TurboMed documentary was very nice, and I think it speaks to you can wear any sort of shoes with those braces. Most braces are not that way. You have a certain pair of shoes that should be matched to your brace. The shape of the shoe, the fit of the shoe, and how it connects to your brace is very important. A lot of our kids say, oh, that brace stinks, I don't want to wear it. They feel like they're tipping backwards, and with the proper heel wedging and the proper shoe, that eliminates that problem. I also see a lot of people spending lots of good time stretching and strengthening and having good bracing, and then they come in with cotton, bunchy socks, and they don't feel that they become bunchy, and they cause skin problems. So good, well-fitting socks are also important. Here's some balance strategies, and with that, I'll turn it over to Robert, who will talk more about balance. But because we were in Colorado, you get a little bit of what I love: skiing modifications and balance strategies in the outdoors.
Everyone, I get the enviable position to hold you before your break. So as I said earlier, I'm Robert Will. I'm a physical therapist on the adult side of the care here in Colorado. And so I'll be talking briefly about physical therapy for adults with CMT. And we're going to start off with balance, because that's probably the most common question I get in clinic is, what can I do to help improve my balance? And so when we're working with people with CMT, we're trying to uptrain two of the systems that keep you upright to almost replace the one that is lost and that is weakened and diminished as CMT progresses. And so you'll see here that it's really, we're focusing on where your head is in space. That's represented by the ear and what you see. And that's the two things that we'll work on. So recently, actually this year, a study came out from the UK where they showed that 10 minutes of balance training in people with CMT 1A for 12 weeks improved dynamic and static balance for those participants. And this chart here is the chart that those researchers used to progress their participants challenging it. So each column on this chart is a way to challenge your balance, and the challenge increases as you go down. So what I recommend, you can actually do this today, is you can use this chart and kind of find out where your balance is. I would recommend starting at the top line and working your way across. And once you do that one, you can kind of change one variable at a time as you go through this. Generally, we say if you can hold a position for 30 seconds with minimal sway, you're not really challenging your balance enough to elicit any sort of change. Conversely, if you can't get into a position or you can't hold the position for about 5 seconds, it's too challenging. So kind of that sweet spot is about 30 seconds at a time with a little bit of sway where you're having to correct with those big proximal muscles that we're going to talk about next, which is strengthening exercises. Gentlemen from Ecuador, I think you'll find this part of it helpful. So these are two exercises that are very good at strengthening your leg muscles and your hip muscles. One of them I would say is probably more important for people, especially adults who have CMT, and depending on how far their symptoms have progressed, and that's the leg press. And the reason is when you have a squat, you are relying on proprioception, or where you are in space, to help you complete that exercise. And if that is diminished, the frame of the, does this have a laser? Oh, no, it doesn't. Green. Oh, there we go. So this frame here keeps him in the position, and he can really focus in on just contracting the muscles against resistance and not having to worry about balancing with a barbell on your back, which doesn't sound very fun. So these are the general recommendations that I've found in the literature for working out, and specifically resistance training for people with CMT. And so the external stabilization, that is using a machine or a frame to help you do the exercise. You want to be more upper leg or hip focused in that as your muscles get weaker distally. And you're going to work out at about 8 to 12 repetitions. And you'll notice here this chart is an exertion scale. So I like this chart because you get these nice, let's see if I can hit that one too. You get these nice buckets of words on how to describe how hard the exercise was. And then you can be a little bit more precise by using the numbers next to those buckets. They recommend that you work out at about a 5 to 8 range. So you're getting into this moderately hard bucket. And everybody in this room will have a different amount of weight that gets you to that point, and that's okay. It's like we talked about earlier, making sure you have an individualized program for your strengthening is really important. So then the last bullet point on this slide right here, monitoring your fatigue for 24 hours after an exercise. You'll see that come back when we talk about the aerobic portion as well. That is a way to ensure that you are dosing yourself correctly while not affecting your day-to-day life. We don't want you to introduce exercise and then not be able to do a shower or anything like that. So we want to keep you in that range. And that doesn't mean if you get into that range that you stop exercising. It just means you dial back a little bit of the exercise. I generally recommend that you take 1 set away of all your exercises and monitor that fatigue, or you decrease the weight till you get to about the 5 or the lower end of this scale. So kind of working out there instead of getting to the 6 and 7 and 8 range. And so finally, one of the questions I get a lot is about aerobic exercise. Again, just like strengthening exercises, it needs to be a safe exercise for you to do. So we will recommend things that you don't do, depending on your ability, making sure. So walking outside with hiking poles, using a stationary bike, swimming, all these things are very, very good, and you can do them if you like them. However, honestly, the best aerobic exercise is the one you enjoy and the one that you will continue to do. Because if I say go swim and you hate to swim, you're not going to do that, which is fine. So figuring that out with a therapist is a good way to go about that. So here are the recommendations for aerobic exercise, and you'll notice I use the same exertion scale here. So aerobic exercise, they want you to be, the American College of Sports Medicine recommends 150 minutes per week of aerobic exercise at 60 to 80% of your heart rate max. How do you determine your heart rate max? You can do it very roughly by subtracting your age from 220. That'll give you a rough estimate of that. And then you just multiply those numbers by 6 and 8, and that'll get you the range of your heart rate that you want to be in. If you have a smartwatch, that's a great way to just ensure that you have that. Or if you have any other way to monitor your heart rate, you can do that. Again, it's going to be the 5 to 8 in this exertion scale, so moderately hard and things like that. One thing that I was reminded of by your talk is using adaptive devices to ensure that you're safe while getting your heart rate up. So if you feel that you can't get your heart rate up without, say, a walking pole or something like that, but you can with a walking pole, I would suggest using the walking pole. So that way you can get into that zone where you're really getting that. 150 minutes, you don't have to go out and start that right away. 2 times a day or 2 times a week, 20 minutes, 30 minutes, whatever you can do. And again, monitoring your fatigue for the next full day, and then dialing back if need be, or progressing if you feel okay with that. And so finally, here is the link to the top tools again, if you missed it on the previous slides. I'm gonna click over to a thank you slide, and then I'll come back to this slide. So thank you so much, we appreciate you. We'd like to open it up for questions, and there's your QR code again.
Oh, you're good. I don't need it. I have the question. So thank you guys so much, you guys. We had 54 responses. So just so you guys know, the majority of people have 1A, 1B. Most of the people are unknown, actually, in what their diagnosis of CMT is. And then 2A, 2M, and 1E, and a CMT sword. So kind of a good bag. And then the majority of people here are 65 to 75 years old. And then there's about less than 20 that are under 25 years old as well. But we have a bunch of questions. So Robert, you kind of touched about this on overwork of your muscles during exercise. We had a handful of those questions. If you want to just kind of do a summary, I think that would be really helpful for the audience.
Yeah. So overworking your muscles, we generally recommend you do not work ever out to fatigue or to failure, to muscular failure. We avoid that at all costs. So that is, you cannot actually do the exercise anymore, cutting off before you get to that point. And if you're working out in that kind of 5 to 8 range with that scale, you shouldn't be touching that. And the nice thing about that scale is that you can tailor it in the moment. So if you're saying, oh, this exercise, I'm getting really fatigued, I'm going to drop it down. It's kind of the art of dosing exercise there.
Great. Yeah, go ahead, Karen.
And what that looks like for your grandchildren would be increased trip, because they're not going to be able to always self-report what that feels like. So you may notice a change in their walking. They may be tripping more. They may be asking for more sitting rest breaks, taking longer naps. So in children, that's what that looks like.
Great. The next question, I'm going to combine a few together. So the biggest one is, how can you work on internal strengthening, internal postural control with sitting, as well as maybe using Pilates? Is that something you guys would recommend?
Yeah.
Or what else?
Yeah. Hello.
In addition,
is this
to
working?
Pilates?
It doesn't. It is.
Yeah.
Okay. Cool. Yeah. Absolutely. Working on internal strength and Pilates is a really great way to do that, because they're decently slower movements. So a lot of times when we work on postural control, we want to think about, okay, sitting upright, right? A lot of us lean our neck forward a little bit. So you want to work on scooching your neck back just a couple of inches. Look at everybody in the room doing it. It's amazing to witness. Everybody's like, you're right. Yeah. So scooching your neck back and practicing that throughout your day, right? Like, we can do this when we're watching TV. We don't, but we should, including everyone. But that's one very, very easy, simple way. And you would be surprised at how quickly you fatigue when you just practice that all by itself. But working on core stabilization, actually exercises that you move a little bit slower on are helpful for core stabilization because they hit those deeper muscles closer to the spine, which help hold you upright.
Caitlin, your posture looks wonderful. Wow. And core strength also helps your balance. So if you're doing some of that work that Caitlin talked about earlier and something like Pilates, it really does help your balance. And then arguably, theoretically, not for all CMT subtypes, but it'll also help your distal function. So if you're building from think of you're stacking a tower of blocks. If the bottom is stable and strong, which is your core, everything that comes from it then theoretically moves better.
So this might be a loaded question, but it's a question a lot of you have asked. How do you find a PT or an OT that knows anything about CMT that is not us?
That's a great question. I'd like to endorse the resource that will hopefully be coming through. We're working on that on the adult side and reaching out to a lot of clinics to find people who have had CMT experience or are willing to learn about it. And I think that's the key. I talk to a lot of groups who have CMT, other muscular dystrophies, where they will go to a physical therapist and that physical therapist has very little knowledge of it. They understand the underlying systems, but they don't understand how they're affected. And so I always recommend, if you can find somebody who has it's called an NCS, or a neurological clinical specialty, that is a good person to go to. They'll have a little bit deeper knowledge of these types of things. And the other thing is if you find a physical therapist who is curious and is willing to put in a little bit of extra time, and it might be you don't do a full evaluation, but they are learning from you on that, that is a tremendous resource. Where if you go into a place where you have a weak foot, let's strengthen that foot, and they don't have any real other questions about it, that's not beneficial. So curiosity and knowing what they don't know, which is hard for a lot of us to admit, but hopefully they do it professionally.
And the CMTA has really great resources on their website that you can point them to if they have a curious spirit in terms of what should be the targets of a therapy treatment. And then also collaboration with the Center of Excellence team is also helpful.
And to echo Robert, for all of you that frantically wrote down NCS, Neurological Certified Specialist, if you go to the APTA.org, the American Physical Therapy Association.org, it says find a provider. You can actually search someone who has a neurological certification and then put in your area code. So it might be that it's not a mile from your house, but it might be 20 miles, and it might be worth going to see someone that has spent extra time, taken a 7-hour test in neurological diagnoses, and understands the pathophysiology of muscle conditions, nerve conditions. So that's the best resource to find someone. And then, Carolyn, there's been some questions about night splints. So the question is, if night splints don't improve range, why do you even do it? And if it does maintain, why don't we do it? If that makes sense.
Yep. So that's a good clarifying. So I should make the distinction. So there's improving range, there's maintaining range. In CMT, maintaining range is a very good goal. And in the article that I cited, I should clarify, they compared no bracing to just with a generalized stretching program with the people who did so stretching and bracing, and just stretching alone was found to be just as effective. The people who go serial casting and then do night splinting keep their correction longer.
Great. I think this will be the last question because we just have a couple more minutes and we want to respect everyone's time. I think one of the things that we should address is using electrical stimulation as an adjunct therapy to PT and OT. Is there evidence to support? No evidence? What's your guys' stance?
Good question. I think you stumped the panel.
Uncertain.
I don't use electrical stimulation. I don't find it it's well tolerated in children.
Agree.
And there is no strong evidence to support its use that I would say it's worth the discomfort and the fight with the child. to make it beneficial. So that's my clinical reasoning. But I can't say, there's no research. Kids don't like it. Therefore, I don't use it.
And I don't use it because I worry about the muscle tiring out too quickly at a level that is not controlled by the patient. However, very similar to Dr. Fridman mentioned earlier, if somebody wants to try it and is willing to kind of not do it if they don't find results, then I'm willing to have that discussion with that person at that time. But I generally don't recommend it.
Yeah, and I'll just add, I think the underlying way that it works is these little pads that stick on your muscle, and they send a signal to your muscles that goes up your nerve to your brain, back down to your muscle, and we know that that connection from the muscle to the brain is impaired, and so that signal might not be getting to where it needs to actually go, and so it might just be impacting the muscles and causing more muscle breakdown without actually encouraging your muscle to work in a manner that, like, if you're doing a dorsiflexion exercise type of thing. That's, I think, all the questions. There was 57 of them, so I tried to do as many as we could. I'm going to plug, we're doing a collaborative research with Stanford University and their neuromuscular team and their bioengineering department, and you don't have to walk. I know it says gait study, but it's a movement analysis, and so if you guys are willing during the breaks to consent, we'll be here all day, and we'd love to get as many different bodies and different abilities to really show the differences in the CMTA community. Yeah.